Okay, well, maybe we should start 6:02. Albert, did you want to begin? And then maybe I can kind of introduce the Toronto Western Fellows and we can get on with our journal club.
Sure, terrific. Yeah, so good evening, everyone. And this is our U of T Spine Program Citywide Journal Club. And I guess as we all, enter this part of the fall, I hope everyone continues to be well and safe. These sort of events over the last while, we've been obviously trying to balance the aspects of safety with sort of in-person gatherings and so forth. And so, obviously the format for tonight will be a bit of a Zoom event. Many thanks to Nadia Jabber for helping to keep us organized and for coordinating the virtual event this evening. And also to our fellows that Michael will introduce shortly as well, who as part of Journal Club have taken a significant role in leading some of the topics for discussion, as well as selection of articles, cases, and facilitating really an interactive dialogue between the faculty and the trainees. So I know there's quite a few folks online, ranging from faculty as well as fellows that have been a part of our program for some time, as well as some new incoming fellows as well, and some of our resident trainees. Everyone, I'm just sort of looking at my virtual screen, and I guess with that, appreciate the fellows for engaging us in an important dialogue, obviously, in terms of the topic for this evening, which will focus on basically the perioperative management of our patients that obviously may benefit from our surgical intervention. Thank you so much. Over you, Mike.
Thanks, Albert. Ohad, do you have your hand up? Do you have a question?
No. Sorry.
Oh, okay, yeah, no worries. Hi, good evening, everybody. So welcome to our University of Toronto Spine Program a journal club. So, we've kind of figured out the art of doing these sessions virtually. And I actually think that the journal club lends itself quite well to a virtual format. So this evening we've got the Toronto Western Fellows, and I'll introduce them in just a moment. I want to thank Nadia Jabber, also our program manager, for her efforts to get everything organized. Also want to thank U of T Department of Surgery, divisions of orthopedic and neurosurgery, as well as our various commercial sponsors as well. Very grateful for their support. We're increasingly dealing with a frail population. We have an aging population, and we also are witnessing the impact on spine care from the COVID pandemic. So many people who have neglected issues and now kind of seeking urgent care. This presents unique challenges to all of us in terms of managing complications, preventing complications, optimizing the outcome. And so that's really kind of the theme of this evening. And recently, there have been some guidelines that were put out by the Congress of Neurological Surgeons. They were published in Neurosurgery, and these deal with perioperative management and optimization of the spine a patient. And I'd like to thank our Toronto Western Fellows for putting this together. Dr. James Wu is sort of coordinating this. We have Dr. Ohad Ainaf, Dr. Carlo Pedro, and Dr. Nasser Elanesi will also be contributing this evening. And our other Toronto Western Spine Fellow, Nader Hijrati, is also contributing by holding down the fort. He's on call. So thanks to Nader as well for handling that. So I think with that introduction, James, I'll hand it over to you and look forward to the presentations.
Thank you for this kind introduction, Dr. Failings. So on behalf of all the fellows here at Toronto Western Hospital, it's an honor to host the first cross-city journal club. So I think the topic of tonight is pre-operative optimizations, a few subtopics that we're each going to present. I think one of the hot topics recently is prehab. So really optimizing patients. And I think in the context of a patient-centered care over paternalistic care, I think we often have to, have patients take into account their own health and make a decision as to, if they want to go down the path of higher complications, or taking matters into our own hands and trying to reduce the complications with us. So on that note, we'll have our first speaker present.
Thank you, James. Thank you, Dr. E. Thank you, Dr. Fellings. I would like to present the first topic of the evening. I'm going to talk about the osteoporosis guideline in spine surgery. I'm going to try to keep the time limit on less than 15 minutes, so please bear with me. Osteoporosis review definition. Obviously, most of you know, but I'm going to repeat on it. Decrease on the bone mass per unit volume or per unit area. The skeleton consists of undergoing remodeling of both bone deposition and resorption, and obviously osteoporosis is an imbalance between the bone reposition and formation. WH classification of osteoporosis probably known for you all. T-score is supposed to be less than 2.5, and Z-score is supposed to be less than 2. I review briefly the osteoporosis of, as you know, three main types: post-menopausal osteoporosis in women who are 50, 60 years of age, senile osteoporosis, both female and male above age of 70, and secondary osteoporosis underlying medical or iatrogenic condition. Regarding to osteoporosis in spine surgery, it was already proved that bone mineral density considered the most important factor in determining the risk of pull out of bone screw interface failure. Osteoporosis associated with thoracolumbar muscular atrophy, that creating a scenario of musculoskeletal instability and later promote for PJK. And a patient with osteoporosis who undergoes cervical spine surgery are more likely to require a revision. Regarding complication in osteoporosis and spine surgery, early below 3 months, compression and pedicle fracture; late above 3 months, pseudoarthrosis, heart failure, screw loosening, adjacent level disease, proximal junctional kyphosis, compression, fracture, and subsidence of the implants. Just for knowledge, epidemiology in Canada: 2 million Canadians affected by osteoporosis, 1 in 3 women, 1 in 5 male will suffer from osteoporotic fracture. Most common area: wrist, spine, shoulder, and hip. Unfortunately, only fewer than 20% of fracture patients in Canada are currently undergo diagnosis or adequate treatment. Osteoporosis costs something like 30,000 hip fracture annually in Canada. And as you can see over here, it's more common than heart attack, stroke, and breast cancer combined. I'll just talk about the epidemiology in Europe, a recent study from 2019. As you can see, 4.3 million phalange fractures in Europe, 11,705 fractures a day, 487 fractures an hour, 8 fractures a minute. It cost them in 2019 56.9 billion euros. And currently, 32 million people suffer from osteoporosis around Europe. Now, regarding our topic, the article goals and rationale is improved patient care, decision-making, tool for education, and review of osteoporosis recommendation. The author had 2 main questions to answer: what the pre-operative diagnosis study that predict the risk of osteoporosis-related adverse event after spine surgery? And does the pre-operative treatment of low bone mineral density decrease the risk of perioperative adverse event after spine surgery? In order to do so, the method was systemic review of literature and evidence-based guideline relevant to perioperative treatment in patient before spine surgery with osteoporosis, evaluation of the transparency in process of making recommendation, guideline developed in educational purpose to assist the practitioner in clinical decision. And as you can see over here, the data was searched in the National Library of Medicine, PubMed, Embase, and the range was from 1946 to 2019. Inclusion criteria was CTL spine surgery, tumor, trauma, and infection were excluded. Patients, all of them had to be above 18 years old. A full article report with clinical study was not medical record review, meeting, or abstract. All the paperwork should be appeared in peer review, minimum 20 patients for each paper. All the papers of humans only, published in English, was not performed on cadavers, not biomechanical study, not in vitro, and quantitatively present results. Rating the quality of diagnostic evidence, the task Multiforce used modified version of North America Spine Society evidence-based guideline. The NAS methodology usually use the standardized level of evidence and grade recommendation to assist practitioner the strength of the evidence in understanding the strength of the evidence and the recommendation. The grades of the recommendation indicate the strength of the recommendation made on guideline based on the quality of the literature, and the recommendation are graded based upon the level of the evidence. As you can see over here, rating quality of the diagnostic evidence, the authors used these to identify the strength and the weaknesses of the study, and basically they divide all the study into 4. Baseline study design, therapeutic, diagnostic, or prognostic. Therapeutic studies review for the following deficiency: failure to provide a high degree of variance, less than 80% of patient follow-up, failure to utilize, no statistical analysis, crossover rate, small patient cohort, and failure. Regarding the methodology of the diagnostic studies, failure to determine specificity or sensitivity, failure in the inter-observer reliability, and failure correction coefficient. Method of prognostic study were a high degree of variance or heterogeneity and failure to appropriately. As you can see, after the authors collect all the studies, they were divided, like I said earlier, into the therapeutic, prognostic, diagnostic studies, and later on, according to the level, high quality randomized trial were level as 1, and case series, case control study with poor reference standard were actually level 4. The strength of the recommendation regarding to rating later on was as the following: A, recommended, which means over 2 consistent level 1 studies or 2 consistent level 1 studies, the same, both of them. B, suggested 1 level study. It's study with additional support of level 2 or level 3, or above 2 consistent studies of level 2 or 3. C is an option. It's level 1, 2, or 3 study with supporting level 4, or 2 consistent level 4 studies. And I was insufficient evidence, which is level 1, 2, or 3, or 4 study without other supporting evidence. Total 6,012 abstracts were reviewed after duplication, that 5,689 were deleted. A double-blind review, 291 abstracts were chosen for the task force members to review. The task force reviewed all the 281 articles, collected data on 78, and selected 17 articles in use to develop the chapter guidelines. So regarding the questions. So regarding the first question, as we can see, 11 articles were superficially addressed this question and met inclusion and inclusion criteria. 4 were level 2, 7 level 3, no level 1 or level 4 studies. The study is evaluated the predictive effect of perioperative serum vitamin D3 level. Was 1 study, and on-time fusion, non-union, CT, and DEXA scan, 10 studies. As you can see, all of the studies are found here. And regarding to the recommendation was perioperative testing with DEXA scan, T-score below 2.5, or a CT scan As you can see here, our serum vitamin D3 levels below 20 nanograms per milliliter were associated with poor bone mineral density, and they can predict the increased risk of post-operative adverse event in individual undergoing spine instrumentation. The strength of the recommendation is B. Regarding the second question, there were 6 articles that superficially addressed the question and met the inclusion and exclusion criteria. 3 were level 2, 2 were level 3, and 1 level 4 study. As you can see them over here. And the recommendation that the clinician should consider perioperative treatment with the teriparatide in patients with osteoporosis who undergoing spine instrumentation to decrease the risk of post-operative adverse event. Okay, the strength of the recommendation is B. And there is unfortunately insufficient evidence to support the use of bisphosphonate alone in patients with osteoporosis undergoing spine instrumentation to decrease the post-operative adverse event after spine instrumentation. The strength of this recommendation is insufficient. Conclusion, perioperative treatment with the teriparatide was associated with higher fusion rate, earlier fusion, and lower screw loosening rate. Undiagnosed and untreated osteoporosis can lead to potentially significant post-operative adverse event, especially obviously in patients that undergoing spine surgery. And a systemic review of literature identified that perioperative assessment with a DEXA scan, CT, or vitamin D3 serum level can predict the risk of adverse event, including lower fusion rate and instrumentation failure in patients undergoing spine surgery. Any questions?
Yeah, so I have one, and what we'll do is after each talk, we'll maybe have 5 minutes of questions, and then we'll have an overall discussion. So for those who are panelists, just kind of show your hand, or you raise your hand virtually, and those in the audience, please use the question and answer the chat feature. So Ohad, you know, we just finished call. We're seeing patients with, we saw 2 patients with fragility fractures involving the odontoid. We're seeing, should those patients be undergoing screening for osteoporosis? And would it be a recommendation that, based on this, should we be referring those patients for parathyroid hormone analogs? What does the evidence suggest?
So the evidence talk in this article, they talk mostly about elective procedures. I didn't see any relation regarding to obviously traumatic patients. Generally speaking, I think that due to the high numbers that I demonstrated at the beginning of my presentation that demonstrate the problem with osteoporosis, I think that osteoporosis is a general problem around the globe today. And yes, I think that there is less treatment of osteoporosis even in our traumatic cases. And therefore, based on what I read, this article and other ones before I prepared this review. So yes, I think that yes, there is a need to send our patient into treatment in osteoporosis.
Dr. Ramprasad has his hand up.
Thanks, Michael. Great summary, Ohad. So one question around the teriparatide treatment is duration to see an effect. So that's always been a challenge in that it's not quick. And so how do you optimize the patient that shows up, has significant, an indication for surgery, and obviously if they can wait, but the question is how long?
So unfortunately, I didn't find in this article the duration of treatment in parathyroid hormone. I think it's important as well. And yes, it's very, very good learning point, which I need to take home message from this from this lecture in order to perform better practice. I think it's important for all of us, and it's very, very important question. Thank you.
Yeah, because it can be over a year.
Yeah.
Yeah, that's been my impression, Raj. I'm no expert on this, but my impression was that you probably need at least about 6 months to see an effect. So I
Right.
think this is kind of maybe, might be applicable for, situations where, that sort of a wait would be acceptable. There's a question here from Samuel Johnson. How effective is denosumab in spine fragility fracture patients?
I don't know about denosumab. It's for further investigation by me, I guess.
Yeah, I'm not sure either. I don't know if anybody knows. Michael?
No, no, I don't specifically know the answer to that question. And again, clinically, it's probably not of great utility because, I mean, you'd have to do a follow-up study looking at bone mineral density just before any surgery that you're doing, because you have to have an endpoint of treatment, right? And there was a cadaveric study years ago to show that bone mineral density of less than 0.6 to 0.8 grams per centimeter squared typically won't hold a screw. Now, it's difficult to assess. You can't do that with DEXA because, of course, it's a 2D study. It's an average of bone densities. And as you know, degenerative disease can spuriously elevate any DEXA numbers. And that dual energy CT is a much better study because you can focus on trabecular bone and you can have a better idea of what the bone mineral density is. And that has clinical application because obviously if the numbers are pretty low, you're going to be much more inclined to use augmentable screws with PMMA. But by the same token, if the numbers are really low, it would hopefully spur people to do fewer instrumented procedures in the elderly. As you know, we're seeing far too many straightforward stenosis cases being fused with instrumentation for no real good reason, no definitive evidence of any gross instability, and no significant deformity that would be potentially indications for using instrumentation. So dual energy CT, obviously augmentable screws if you need them, or even better still, don't use screws at all in the elderly patient with probable osteoporosis.
So on that note, James, maybe back over to you to introduce the next speaker.
Yeah, so next up we have Carlo, who is one of our fellows from the Philippines, neurosurgery background, who's going to be talking to us about the preoperative nutritional assessment. Well, go ahead, Carlo.
Okay, can you hear me well?
Yep.
Yes.
Okay.
Yes, we can.
Yeah, good evening. It's my honor and pleasure to join to you and present in this year's journal club. I am Carlo Pedro and I'm presenting the second guideline on perioperative spine management, specifically on the preoperative nutritional assessment. So this will be the outline of my discussion, beginning with laying the theoretical foundation, starting with the definition, the prevalence, as well as the impact of malnutrition in spine patients, to be followed by highlighting the key points of this guideline on perioperative nutritional assessment. And I will end my talk by looking at the pragmatic lenses and how these recommendations are being adopted and reflected in the current practice as we have now. So as we know, malnutrition is not only refers to deficiency, but also excess in nutrients, leading to several adverse effects in the body. We have come a long way in our understanding of the role of nutrition, specifically in the treatment of several diseases, starting with Hippocrates, who happens to be also the father of spine surgery, saying that food should act as medicine and medicine be thy food, to significant discoveries of micronutrients and to the current knowledge that we have on immunotherapy as well as personalized medicine to target specific nutrient deficiencies. The prevalence of malnutrition is surprisingly high. In this study of hospitalized patients, it is estimated that around 45% have some form of malnutrition even before hospitalization. And in the context of spine surgery, it is estimated that around 25% or 1/4 of these patients have some form of nutritional deficiency even before undergoing surgery. And stratifying this by age, we find that around 40% of patients who are aged greater than 60 are malnourished prior to undergoing surgery. The importance of nutrition in surgical patients is highlighted by the fact that these patients undergo a condition called systemic inflammatory response after surgery. And this condition is highlighted by upregulation of both glucose and protein metabolism to keep up with the demands of wound healing as well as functional recovery. It is therefore very important to make sure that in order for dysfunctional recovery to occur, or what we call the restituto ad integrum, it is very important to ensure that optimal nutrition there's optimal nutrition in all patients undergoing surgery. What this means to us surgeon is really to look at all the opportunities within the perioperative period to ensure that our patients have optimal nutrition. And this guideline will help us in this task by providing an evidence-based recommendation in terms of nutrition risk screening as well as nutritional intervention. So as you know, this guideline on nutritional perioperative assessment was recently published in the Red Journal. And this guideline on nutrition is headed by Dr. Beeson from Utah, who spearheaded a review of a sizable number of papers. And in the end, including 13 papers in this guideline, 12 of which have retrospective study design and one with an RCT framework. So currently we know that spine surgery is associated with improved pain, function, and quality of life, and that surgical complications sometimes happens, and this results in significant morbidity and poor outcome and poor patient satisfaction. Across several surgical specialties, they find that age, BMI, diabetes, smoking, and particularly nutrition predicts poor outcome. But despite this knowledge that we have, there remains to be a significant knowledge gap in our understanding of the role of perioperative nutrition. And these questions are summarized in these three statements, which this guideline seeks to answer. So firstly, what preoperative serologic studies of nutritional status are predictive of adverse events? Secondly, are there non-serologic assessment tools that we can use in lieu of the serologic studies that are shown to also predict adverse events? And lastly, in a setting of malnutrition, is treatment necessary and evidence-based? And are these shown to really decrease the risk of adverse events? So in terms of the first question, what serologic studies are available that are known to predict adverse events? This guideline recommends the use of serum markers, specifically albumin, pre-albumin, total protein, albumin globulin ratio, which are shown in studies to be associated with multiple adverse events. Specifically, the task force members recommend using a cutoff value of less than 3.5 for albumin and less than 20 milligrams per DL for pre-albumin. And they also recommend that as clinicians should assess their patients routinely to assess their nutritional status pre-operatively, and in order for us to counsel them on the potential adverse events. And these adverse events include the risk for wound complications, non-union, and hospital readmission. So the relationship between nutrition and surgical site infection is proven in study by Salvetti in 2015, where in a case control study, they showed that patients who have low levels of pre-albumin have higher risk for developing SSI. This same conclusion, this same finding is proven in the prospective study done several years after by the same author, using more patients, around 300 patients, and again, proving that decreased level of pre-albumin were associated with 3 times increased risk of developing SSI. Using albumin and total protein also showed the same conclusion as that of pre-albumin. So this study on the left by Wang in 2017 enrolled around 8,000 patients, and they have shown that low levels of protein, albumin, as well as the albumin globulin ratio is independently associated with increased risk for developing SSI. The same conclusion was made by Lee in 2019, where patients who developed SSI were shown to have low levels of operative serum albumin compared to those cohort that did not develop SSI. The rate of pseudoarthrosis or non-union is also impacted by the fact that low levels of serum albumin. And this is studied by Inuse in 2018, where the authors seek to evaluate serological risk factors for non-union by following 74 patients for 1 year with a CT scan showing an 18% rate of non-union. They found out that patients who have low level of preoperative albumin in fact turn out to have higher rates of non-union compared to those patients who have normal albumin levels. The hospital readmission rate is likewise affected by nutritional status. This is study by Adogwa from Duke University showed a three times increased risk, and this study by Fan from Australia showed increase by 2.7 times increased risk of unplanned hospital readmission in patients with low levels of albumin prior to surgery. This guideline also set forth some evidence that malnutrition plays an important role in determining outcomes in elderly patients who undergo spine surgery. This prospective study from Johns Hopkins University enrolled 960 patients aged 65 to 84 years old, and they have shown that patients who are malnourished or those elderly who are malnourished have worse outcomes in terms of higher 90-day major medical complication, higher 1-year mortality, higher post-operative infection, as well as higher wound dehiscence. This holds true also in special patient population who undergo spinal deformity surgery, which we know involves multiple levels and several segmental osteotomies. And using the NSQ IP registry, Fan and colleagues have shown that patients who undergo spinal deformity prior to surgery who are hypoalbuminemic have higher risk of developing poor outcomes in terms of higher post-operative complication, 30-day mortality, and increased length of hospital stay. As for the second question, are there non-serologic tests in lieu of this serologic or those prior serologic laboratory tests that are shown to be predictive adverse outcomes? And this guideline have shown that there is insufficient evidence to recommend any non-serologic assessment tools. In particular, the literature search did not identify any studies that specifically address this question. I went further to research on these non-serologic assessment tools and found this article by Cross, where they summarized quite succinctly in this table the available non-serologic assessment tools, which include anthropometric measures as well as standardized scoring tools, as shown in this third column. But they also pointed out the limitations of these studies in that they cannot detect acute undernutrition, and they must be formally tested in big studies, even if they are adopted from validated surveys. And I think these limitations are also the reason why we have positive literature in terms of these non-serologic tests. And lastly, for the third question, in a setting of malnutrition, is intensive therapy indeed shown to be cost-effective and evidence-based? And in this guideline, the task force members showed that there's insufficient evidence to support the use of perioperative multimodal nutritional management to decrease the risk of adverse outcomes. So the members specifically recognized that in other specialties, some of the available options include preoperative carbohydrate loading or protein supplementations. But in spine surgery, there's really a positive literature evaluating the impact of this nutrition-based intervention. One study is worth mentioning though, and this is a study by Su et al. In 2019, where they randomized 187 patients into an M&M group and a control group. The M&M group received several protein and carbohydrate supplementations prior to surgery and also underwent an early feeding program. And these authors have shown that indeed those patients receiving NMN therapy have lower risk of albumin transfusion, lower levels of electrolyte imbalance, and shorter length of stay compared to the control group who had increase in wound drainage. However, the conclusion of these studies must be tempered by the fact that they employed healthy population, and so they may not be representative of the population where we normally would recommend this therapy. And I think this is the reason why this receive a low level of evidence in this guideline. So in summary, this guideline really helped us to answer 3 questions, and it recommends the use of serologic markers, including albumin, prealbumin, total protein, and albumin globulin ratio. And there's insufficient evidence for non-serologic tests, as well as intensive nutritional therapy prior to undergoing surgery. And before I end this and end my talk, I would just like to show to you 2 current practices that are 2 emerging practices where nutritional preoperative optimization is being practiced, specifically one in ERAS, or the enhanced recovery after surgery, which we know is an offshoot from the from our colleagues from colorectal surgery, with the aim of providing a protocol-based perioperative management in patients to optimize their outcome. And there are several ERAs in spine. One of these is shown in this slide in patients who undergo lumbar fusion. And really, you can see how nutrition is being emphasized in the preoperative state or preoperative phase. In a systematic review, just for additional information, currently there are 19 ERAs protocol in spine which have shown improved pain outcome, but really no change in complication rate and readmission rate. And this is compounded by the fact that these protocols have variable population and variable implementation protocols. And lastly, we are starting to hear more about pre-habilitation and nutritional support. This is one of the protocols from Duke University. And really the concept of pre-habilitation is providing an alternative route for these patients to optimize the nutrition, nutrition by modifying their behavior prior to surgery. And this is in the setting of what they call surgery schools, where these patients are educated about these practices. And early results have shown encouraging outcomes, but we are still awaiting for more definitive results from larger studies. So in conclusion, this guideline on nutritional assessment encourages a surgeon to routinely assess our patients prior to surgery using serologic markers, such as albumin and prealbumin. Definitely, there are more room for improvement over this guideline, specifically the looking into or having more definitive studies for non-serologic tests, as they are cheaper and more readily available, and certainly the development of spine-specific nutritional protocols to optimize the nutrition of our patients. That will be for my part. Thank you.
Thank you, Carlo. Excellent. Jeremy LaRouche has his hand up.
Yeah, thank you, Carlo. That was great. My question for you is, how quickly do you think that malnutrition can become an issue? And what I mean by that is we often have patients that are NPO for 6 days or 5 days in a row before they can finally get to the operating room. And often they're not fed until late in the evening. So how quickly does this malnutrition effect take place? Is there any evidence behind that?
Yeah, so thank you for that wonderful question, Dr. LaRue. And I really understand where you're coming from. And I think this is the reason why they only included patients here who undergo degenerative surgery, and excluded really those patients who are receiving more urgent surgeries like trauma, infection, or even tumor, because at least with the degenerative surgery patients, they are given more time to prepare for surgery. And also, this is the reason why I think non-serologic tests are not able to detect acute, are not recommended in this guideline, as they cannot detect acute changes in nutrition. So so definitely for those acute trauma patients, we cannot do routine pre-op nutritional testing, but those patients who can wait, say, a month, 2 to 3 months, maybe we can look closer into their nutritional status prior to surgery.
Michael Ford, you got your hand up? I think you're muted. Yeah.
I was a little bit surprised that the paper didn't include any mention of the assessment of sarcopenia with the Psoas and vertebral body ratios at L3. I mean, that's something that's been fairly extensively studied. There's 4 really good papers out of Vancouver who look specifically at sarcopenia, nutrition, frailty index in a bunch of different groups, those undergoing minor degenerative cases and those undergoing emergent metastatic surgery. And certainly there's very strong correlation between the ratio between the Psoas volumes and vertebral body volumes at L3 and then subsequent complications, especially 1-month mortality rates. And that if your numbers are below 1, for instance, for that Psoas vertebral body ratio, it was very predictive of early mortality. So I'm surprised they didn't talk about that at all.
Yep. Thank you for that, Dr. Ford. Yeah, so I think those are one of those tests included in non-serological tests, although not specifically mentioned in this guideline. And I think that is also one room for improvement for this guideline, to include those tests in subsequent guidelines for pre-op nutritional assessment.
Chris, thanks for the comment. I don't know if Chris Nielsen if you're available to comment. I was going to ask Chris to comment on the ERAS concept and some of the efforts that are going on at UHN on a pilot basis.
Thank you, Michael. I think there's been lots of, points already brought up, and we're going to go over more in terms of our optimization of these patients. And more, we're recognizing frailty as a clinical measure of basically, a person's fitness for surgery and ability to withstand stress. And certainly nutritional status plays a big role into that, as well as osteoporosis. And so one of the groups that works at UHN in terms of a group looking at pre-habilitation and trying to optimize nutritional care and look at smoking status and overall physical fitness and trying to improve that prior to surgery. So we've just started working with that. In fact, at UHN, that group has received a sizable grant to study all surgical patients, and we're trying to make a push to make sure that we have spine patients included in that. So, I see a lot of changes, coming down the pipeline, at least to, try to identify where we can make a difference, in the perioperative care for these patients to try to improve their outcomes and decrease their rate of complications.
Yeah. Thanks, Chris. So, lots of interest in this concept of pre-habilitation and frailty and so on. James,
Yeah.
we will take a question from Dr. Ramprasad, and then, yep.
Just quickly to circle back with Mike's thing. I mean, sarcopenia and nutrition obviously are interrelated, but not mutually exclusive. So I think from a systematic review perspective, they may not have gotten into things where they're not specifically looking at nutrition alone as to why it was not discussed in those papers. And it's a hard thing to disentangle, but frailty, sarcopenia, all these things kind of cross over, but there are different entities in that you could be sarcopenic and not have malnutrition, etc.
Yep, good point. Good point. Certainly the big area of interest in also the cancer area for sure.
Yeah.
Very good. So thank you for the comments. James, back over to you to introduce the next speaker.
Yeah, so up next we have Nassim Al-Nezi, who's one of our fellows from Saudi, who's an associate staff at Riyadh. He's going to be presenting on surgical risk assessment, as led by Dr. Nielsen.
I have this one. Can you show me presenter view?
No, there's no presenter.
Hello, good evening, everyone. Can you see my slide?
That looks good.
Yes, we can. Yep.
Okay, so okay, just a minute. Okay, so again, good evening, everyone. Thanks for the introduction. It is my great pleasure to be involved in this highly academic program and be one of the fellows at Toronto Western Hospital. I want to start my presentation and my part for this review from the Congress of Neurological Surgeons systematic review, and my part is regarding the preoperative surgical risk assessment. As introduction to the topic, first, most of the spine surgeries are performed elective base, and this affords the surgeon and the preoperative team the opportunity to evaluate an individual patient for the risk factors to potentially optimize these factors before the surgery. And diabetes, obesity, and smoking are three prevalent comorbidities that negatively impact the health status and increase the cost, also have been implicated in a worse outcome after spinal surgery. There is a lack of the consensus regarding which factor should be screened and potentially modified preoperatively to optimize the outcome. This clinical guidelines was created to improve a patient care by outlining the appropriate information gathering and decision-making process involved in the treatment of the patient and perioperative spinal disease. Also, this guidelines has been created as an educational tool to guide the physician through the series of diagnostic and treatment decision in effort to improve the quality of the care. One of the objectives of this review is to determine the preoperative diagnostic studies that predict increased risk of the reoperation or surgical site infection in a patient with diabetes first. In addition, the published literature was assessed to determine if increased BMI correlate with increased risk of reoperation or surgical site infection. Finally, if the impact of the preoperative smoking and risk of the reoperation after spinal fusion was evaluated, and if smoking cessation decreased this risk. There is a three main question for this review. The first one is in the patient with diabetes undergoing spine surgery, what preoperative diagnostic studies predict increased risk for reoperation or post-operative infection? And second question, is increased body mass index associated with increased risk for reoperation or post-operative infection for a patient undergoing spine surgery? And the third question, is preoperative smoking associated with increased risk of reoperation? And second part of the question, does preoperative smoking cessation decrease the risk of the reoperation? This is a systematic review article included from 1946 to September 2019. Regarding the inclusion and exclusion criteria, it's the same for the whole series of these studies. And to reduce bias for inclusion and exclusion criteria were specified before conducting the literature search. A recommendation for and a grade system, they used the modified version of North America Spine Society evidence-based guidelines. And here is the table showing the recommendation, which is A, B, C, and I, already explained by my colleague Ohad. And this guidelines, it's help to assist the practitioner in easily understanding the strength and evidence of the recommendation within the guidelines. So the initial literature search relevant to all chapters in this guideline series and yielded in more than 6,812 abstracts. After a double-blind review of the literature, they found around 699 abstracts related to these three questions. They identified the literature full text articles, and the task force selected around 192 articles, and they end with 64 articles included in the to answer these questions. First, the first question, in the patient with the diabetes undergoing spine surgery, what preoperative diagnostic study predict increased risk for reoperation or postoperative infection? And the recommendation here, the diabetic individuals undergoing spine surgery should have a preoperative hemoglobin A1C test before surgery and be counseled regarding increased risk of reoperation or infection if the level more than 7.5, and the strength of the recommendation is grade B. Second part of the recommendation, there was insufficient evidence to support other preoperative diagnostic studies like preoperative blood glucose level. There is there were 5 articles in this review demonstrating the relationship between increased hemoglobin A1C and risk of reoperation or infection after spine surgery. Most of these studies defined the controlled diabetes as hemoglobin A1C as less than 7. There is one study taking hemoglobin A1C high threshold for that and showing a different results. Here is the 5 articles showing there is a significant correlation observed between the hemoglobin A1C and reoperation and the infection rate. And the inflection point for the infection by hemoglobin A1C level was more than 7.5. Interesting, there is one study here analyzing more than 3,000 patients. The results showing preoperative blood glucose level more than 140, double the risk of surgical site infection, and they didn't identify the correlation with hemoglobin A1C measurement preoperatively. For the second question regarding the body mass index, is body mass index associated with increased risk of reoperation or post-operative infection in patient undergoing spine surgery? And the recommendation is there is a conflicting evidence that increased BMI is associated with a greater risk of surgical site infection in a patient undergoing spine surgery. Given a number of studies demonstrating a correlation between BMI more than 30 and SSI, particularly with the lumbar surgery, the task force recommend that the clinicals counsel patient with elevated BMI regarding this possible risk and grade insufficient still. The other part of recommendation, there is still conflicting evidence that increased BMI is correlated with an increased risk of reoperation after spinal surgery, and strength of the recommendation is grade insufficient. For these studies, they defined the BMI more than 30, and there is more than 42 studies trying to answer these questions. Some of them related to the risk of the infection, and the others risk of the reoperation. They divide these studies for cervical and for the lumbar, and some of them for the thoracolumbar together. Most of the lumbar surgery studies were level 2 and noted a positive correlation with increased BMI and higher risk of the surgical site infection. Here is the number of the studies in the lumbar and cervical and level of the evidence. As you can see here, most of the studies were lumbar articles. Around 31 articles, most of them level 2 studies showing there is a direct correlation between increased BMI and surgical site infection. 11 articles showing there is no significant difference. In the cervical studies, there is 5 articles. 3 of them showing direct correlation and 2 of them showing there is no significant difference. Regarding the other part of the studies which correlating BMI and risk of the reoperation, also still the same, there is a conflicting evidence. But there is interesting articles by Ren et al. Analyze a 4 years post-operative follow-up from the sport degenerative spondylolisthesis trial, and he observed twice the reoperation rate after at 4 years for a patient with BMI more than 30 compared with those with a BMI less than 30. It's about 20% versus 11%. However, did not negatively impact the overall clinical outcome. The last question in this review regarding the smoking, and the question is pre-operative smoking associated with increased risk of reoperation in the patients undergoing spinal fusion surgery? Does pre-operative smoking cessation decrease the risk of reoperation? And the recommendation for this question, individual undergoing spine fusion surgery who are active smoker should be counseled regarding increased risk of reoperation, and it is a grade B. The second part of the recommendation, there is insufficient evidence that cessation of the smoking before spine surgery decreased the risk of reoperation, but it is suggested that patient be counseled to stop smoking before and after spine fusion surgery, and grade insufficient. There is around 8 studies answering this question in this review. 6 of them showing a positive correlation between the smoking and reoperation after the surgery. The reoperation cause, according to some of these studies, because of the pseudoarthrosis, and some of them because of the infection. There is 2 studies assess the relationship between smoking and reoperation in patients with adult spine deformities. The first one reported there is associated between the history of smoking and increased risk of the reoperation. And the second studies resulted in higher reoperation rate among the smoker, but this was not significantly, it's not statistically significant, as well as it's a grade 3 studies. Last, there is one study for a patient required reoperation for the surgical site infection after spine surgery. And this study showing the results of tobacco use was the highest predictor of reoperation for the surgical site infection. So in conclusion, there is still remain significant work for a pre-operative optimization for spine patients, particularly define the target goals that patients should meet to reduce the pre-operative risk, and the timing of these intervention are needed. And the future directions should focus on optimal pre-operative goals to maximize the post-operative outcomes in the term of pre-operative weight loss, smoking cessation, and diabetic blood sugar control before the surgery. Thank you.
Thank you, Nasser. Very good summary. If there are any kind of questions or comments, I'm going to ask you a question, Nasser. So for you, what were the big pearls that you got out of kind of reading this article?
Okay, so the big message taken from this articles, it's regarding counseling the patients pre-operatively regarding all of this risk, and let patients know about it, especially for diabetic patients and obese patients and the smoker group patients.
Okay. Very good. Well, let me introduce, Raj Ramprasad has raised his hand. Dr. Ramprasad.
Thanks, Nasser. Perhaps you can make a comment on, a lot of the studies are from the US, et cetera, but prevalence of diabetes, particularly type 2, is extremely high in your country of origin.
Right.
And sort of the general Middle East, I know it's a big problem. It's obviously a big problem in our indigenous population in Canada, and the data is very sparse in these very high risk populations where I think the disease is much more prevalent and typically more poorly controlled. So I think there's a bit of a bias in some of the studies, and certainly there's inconsistencies, as you alluded to, but it'd be interesting to hear your comment on what is being done about diabetes and perioperative management in Saudi.
Sorry, say your question again.
So what is being done about perioperative management of diabetes in Saudi, where it is a much more prevalent issue?
Okay, as you mentioned, we have a lot of patients actually with type 2 diabetes in the Middle East. And usually we're trying to optimize the patient by sending them to a medical team to optimize the blood glucose level and hemoglobin A1C before going to the surgery. Just try to help them for a surgical option. In my institutions, most of our patients are trauma patients. So it's most of them, it's urgent basis. So there's just a few less time, to go for a surgery.
Okay.
Thanks.
Thank you.
I can
Dr. Ainaf Ohad?
Yes, I can answer some of the questions regarding what Dr. Ramprasad just asked, just on my practice back home. And I will add another question to Nasser. So generally speaking, so patients with H1AC above 7 usually are not getting into the OR for elective cases. So that's usually the common practice. Obviously above 5.8 or above 6, obviously we usually ask for endocrinologists that deal with diabetics to get into the picture, as well as general practitioner. This is regarding diabetes. Regarding smoking, which is kind of common in the Middle East as well. So as far as I know, it's a cessation of something like between 3 months to half a year before any elective surgery in most of the places right now in Israel. Regarding spine surgery, a lot of centers right now in Israel refuse to perform elective cases in smoking patients. And my question for Nasser is, did you find anything like guidelines regarding the smoking cessation pre-op in your article?
No, actually, this is the insufficient. There is no any articles addressing the smoking cessation before the surgery. They only address the first part of the question, which is related to the reoperation or surgical site infection, but there is no any articles in this review regarding the cessation of the smoking.
Thank you.
Thank
Great.
you.
Okay, I'll call on Dr. James Wu, our one of our fellows and the coordinator of this evening, to present the final paper.
Thank you. Just pull this up. So my topic will be on preoperative opioid evaluation. So just full screen. All right. So I think a little bit of a background. So I don't know if this name is familiar for some people. Purdue.
Can you put it on? It's on presenter view. Can you put it on your display? Can you switch?
It's better. I did not have this view before.
It's a, oh,
Is this better?
Yeah,
Yeah.
that's better.
Okay, perfect.
yes.
So Purdue famously or infamously came up with OxyContin in the late 90s, early 2000s, had an aggressive marketing campaign really towards the more liberal use of opioids for chronic chronic non-cancer related pain. And they really promoted it as a very safe and non-addictive medication. They spent about $200 million at the peak of their campaigns in 2001. They lobbied really aggressively among MDs and GPs. They even had a marketing scheme where they would target, they would look at records and see which physicians would prescribe opioids more liberally and try to lobby towards them as well more aggressively. And I think this was really one of the reasons that kind of stemmed the opioid epidemic in the US. And I think that also spilled into Canada. I think the last 5 to 10 years, we've been much more conscious in use of opioids, especially in chronic pain. And as we all know, a lot of spine patients are facing this problem. About 50% of our patients will have had some degree of preoperative opioid use, which I think is quite significant. And patients hospitalized for spine conditions, there's been an annual increase in the last 10 to 15 years, about 6.5% increase of opioid use disorders. So in the last, between 2010 and 2014, there's 25% more opioid use disorder compared to the previous 5 years. Right now, there's a paucity of evidence to pre-op opioid dose and duration for surgical degenerative spine patients. So there's really no guidelines for GPs and pain physicians. And definitely in our context, there has been very little study in terms of preoperative weaning of opioid medication. So in this kind of consensus, the task force did a systematic review of literature, looked at 6,812 abstracts, and then narrowed it down to 41 articles, including systematic studies. So there's no level 1 studies, and most of them were level 2 studies. So their first question was, does the duration of preoperative opioid use impact opioid use postoperatively? Whether it's the duration of use, the milligrams of morphine equivalent, so the dosage, the patient-reported outcomes or adverse events of spine surgery. And the conclusions, which I think is seems fairly logical to us, is that the longer duration of opioid use before spine surgery is associated with worse outcomes, whether it's patient-reported outcomes, complications, or post-operative chronic opioid use. So that was a grade B recommendation. So they kind of compartmentalized cervical and lumbar papers. So kind of a summary of cervical papers. Oftentimes the pre-op chronic use of opioids was defined as more than 3 months of use prior to surgery, and some papers more than 6 months. So the odds ratios of chronic post-op opioid use in patients using a pre-op versus opioid naive patients was 5.7 times more likely. And 50% of patients using opioids pre-op were still going to be filling opioid prescriptions at 1 year. So risk factors for post-operative chronic use was drug abuse, depression, anxiety, tobacco use, and Medicaid in one of the studies. Again, patients undergoing cervical fusion have a lower return to work, more disability, and higher costs if they have chronic preoperative use. Surprisingly enough, this was also related to wound complications in some of the studies. Obviously, more return to ER and specifically pain-related ER visits. And they also had worse surgical outcomes, and they had to have more repeat cervical fusions or injections within 1 year from their index surgery. On the lumbar side, again, they've categorized chronic use as 3 months or up to 6 months preoperatively. There's mixed studies of decompression only, discectomies, as well as fusions. So in discectomies, the odds ratios of chronic post-op use, if you use opioids preoperatively, is 3.4, which is, I think, not as significant as if you instrument it with fusion, which is 220, and that's not a typo. So patients who are using opioids preoperatively, I think we should reconsider strongly the indications for fusion, as they have a higher likelihood of having significant amount of pain and opioid use postoperatively. So again, other risk factors, which I think are fairly similar than the cervical ones: fibromyalgia, migraine type disorders, depression, and smoking. Interesting, I think one of the studies compared MIS versus open TLIF and found that MIS was a protective factor against chronic post-op use of opioids, I think, at 1 year. Those that use preoperative opioids chronically had a increased odds ratio of length of stay of more than 5 days for their surgery, global surgical complications, cost of care, again, 90-day emerge visit or readmission, again, wound complications, which I'm not too sure how to explain that, and then again, failure of surgery requiring revision within 1 year. The second question was kind of similar, but more specifically, if the dosing of their preoperative use, so the milligrams of morphine equivalent, affected their duration of use or dosage post-op, again, patient-reported outcomes or adverse event after spine surgery. So their recommendation was that any use, no matter the dose, was associated with risk of longer post-operative use of opioids and worse clinical outcomes and patient-reported outcomes. Again, no level 1 study, mostly level 2 studies. I think one of the big issues with this meta-analysis, or sorry, the systematic review, was a lot of the articles didn't specifically discuss milligrams of morphine equivalent dosage, but more in terms of absolute, if they use opioids or not preoperatively. And some articles, they kind of gave this vague classification of weak versus strong opioids. So here's kind of a refresher chart of conversion factors. So if morphine is one, we typically prescribe hydromorphone, which is 4 times stronger, and then oxycodone as part of Percocet, which is 1.5 times stronger. So again, they compartmentalize cervical and lumbar articles. So in the cervical part, again, higher likelihood of chronic use 9 days after surgery if they use it before, and at 2 years as well. So it increases actually their odds ratio increase of chronic use at 2 years if they use it pre-op. They have worse 2-year outcomes. For workers' compensation patients, they have a lower likelihood of return to work. Again, worse outcomes as well in terms of reoperations and then requiring injections. Interestingly enough, they had, again, higher adverse events in terms of constipation, which is pretty obvious since it's one of the major side effects, but also kind of medical complications such as deep vein thromboses, acute kidney injuries, infections and wound complications, and neurological complications in general. In the lumbar category, again, worse functional outcomes, higher odds of not achieving significant improvement from pre-op, higher dissatisfaction rate, and higher pain scores. So one of the studies showed that the cutoff to achieve a clinical significant post-operative outcome was really 47.8 milligrams of morphine equivalent versus 90 milligrams of morphine equivalent, which is roughly, I think if we convert it to the lauded or hydromorphone that I think is the most prescribed, would be about 10 milligrams. So if it's taken every 4 hours, probably 2 milligrams every 4 hours, which I think is in the realm of the average chronic pain patients that we see. Again, if they have pre-operative use associated with chronic use and longer post-operative use. Interestingly enough, deformity was one of the exceptions where they found some protective factor if you use pre-operative opioids, in the sense that although they had greater post-operative initial pain scores, they had a greater decrease from their baseline score. So kind of the margin of improvement was greater in deformity patients if they used opioids pre-op. They also had a greater number of first ambulatory steps post-operatively, and their SRS score at 2 years was actually a bigger improvement than non-opioid users, although the ODI was similar. And actually, the last question, which I think was the most clinically important for us, is there any use in weaning opioids preoperatively to decrease post-operative use, improve outcomes, and decrease adverse events? And unfortunately, there's insufficient evidence to make any recommendations. So on that note, I'll leave some discussion points up in the sense that who should be leading the weaning discussion? Should it be the family physician who, because of COVID now, most of the patients are complaining that they don't even see their GPs anymore? Should we involve APS preoperatively as well for kind of pain management counseling? Do these kind of, does this paper at all influence your decision making, your discussion with your patient in terms of expectations? And then I think one of the things that's very important is how do we manage post-operative analgesia? Yes, we have APS involved, I think, in most of the spine patients, but at the end of the day, it's oftentimes the surgical service that writes out the discharge prescription, which often falls down to one of the residents, and that nobody really teaches us how to prescribe or what dosage to prescribe. And so this can be very variable. And again, there's very minimal guidelines in terms of standardization of dosing and duration of narcotics for various typical surgeries. So I think those are discussion points. And that's my talk.
Thank you, James. Very challenging topic for sure. Okay, some hands raised. Chris Nielsen first, and then Albert Yee.
Yeah, thanks, James. Good job summarizing that. I think your question one for your discussion, who should be responsible for weaning, is an important one because I know there's not a lot of, I know patients run into a little bit of a challenge trying to get on a good sort of tapering schedule, and it's a long, arduous process, and it's probably something that should be at least more centralized and have people that are involved in getting some of these patients off these medications. I have one patient who I operated on who was deprescribed by one of our anesthesiologist at TGH who does that. As a note, in 2020, the last CSS in Whistler, there's a group out of Calgary, and a friend of mine who's a psychiatrist who's got himself involved in deprescribing in the opioid epidemic, and they presented a couple good papers on improved outcomes in spine surgery patients, specifically in the adult spinal deformity patients with lower complication rates, improved sort of discharge to home. So I do think there's some emerging evidence out there that would support deprescribing. The question is, who do we champion to get this done? Because it's one of those areas where a lot of our patients, I think, would benefit. We just need somebody to sort of take the reins.
Yeah, totally agree. It's very, very difficult and long process. I think from a surgical perspective, I don't think it's feasible, just given the length and time requirement. And I think a lot of family physicians, I think, feel that it's beyond their capabilities and would rather just write another prescription than deal with this.
Challenging for sure. Albert.
Yeah, that's great. I appreciate this update. I think clearly there remains a lot of opportunity for us as a group, and perhaps even something to think about sort of citywide. I know, there are a variety of groups that have sort of looked at, the typical type of regimen that would be sort of necessary potentially after sort of common types of procedures, including sort of lumbar procedures. And I think one of the residents at our ortho research day last week actually did a bit of a study just sort of looking at our sort of resident prescribing pattern and procedures and comparing plastic and orthopedic surgical residents. And there's quite a difference. The orthopedic residents tend to prescribe a lot more of the opioids than our plastic surgical colleagues. And in the survey of sort of what guided the trainees in terms of what they prescribed, it was basically dictated, the most significant factor was really what their faculty preference was, or what they thought their faculty preference was. And so I think there's perhaps opportunities for us to sort of think about maybe harmonizing things a little bit more and looking at it a little bit more closely. The other things that we've done at Sunnybrook and at the Holland Center as well with our arthroplasty group, Bhishma Ravi, one of our joint surgeons, has also put up a recovered program where basically after surgery, patients and their families are sort of provided the opportunity to bring back opioids, and they're disposed of safely and by pharmacy in a controlled manner versus sort of ending up in a shelf somewhere or potentially ending up on the street and things like that. And the amount of opioids recovered is not insignificant. And so I think that also suggests that perhaps there may be an opportunity to look at our prescribing practices.
Yeah, great comments. Yeah, it's a big issue. Certainly one of the big opportunities we have, though, is to the correct management of opiate naive patients who are undergoing surgery, and to be very circumspect and with the use of opiates, particularly once people are discharged. Well, we've had 4 excellent presentations, a lot of discussion, a lot of interest, I think. It's very, very practical here. So before we close it out, any final comments or questions from everyone? Just while we're kind of waiting for that, just thank you to James and Ohad and Nasser and Carlo for an excellent job of summarizing and very thoughtfully presented, and really kind of appreciate that. I think there's a lot of useful pearls there for all of us to consider and to reflect upon. Very good. Okay, well, maybe we'll just close it out. Albert or Nadia, any final announcements before we close it out? I guess a shout out for Steve's course on Wednesday. It's a busy week. Steve Lewis, any comments on the course?
Yeah, Nadia's done an awesome job getting us ready for it. There's 12 fellows, there's 3 cadavers, and Chris and I are going to hopefully give you guys a good time to get a chance to really have an opportunity with the cadavers and learn techniques and skills that you guys are hoping to achieve. Everybody's desires will be a little bit different, and we're going to try to accommodate, if we want to accommodate more C-spine or more osteotomies or more approaches, we'll try to do our best to give everybody the touches and the needs that they need for the course. So looking forward to it. Great.
Well, big thanks for putting that together, Steve, and thanks also to Chris and Nadia. Thanks for the logistical support, and thanks to industry for the support as well. Very good. Okay. Well, thanks everybody for your participation. Thanks again to the fellows and Nadia, and I guess Steve, we'll wish you bon chance with the course. It sounds like it'll be a fantastic educational offering.
Yeah, Nadia's done an awesome job getting it ready. So a big shout out to Nadia for it. So.
Cool. All right. Thanks everybody. Good night.
Thank you, everyone.
Thank you.
Good night.
Everyone.